Hey everybody, it's Group 1 coming at you with our presentation on research and treatments for Alpha-1 antitrypsin deficiency. Next. So as we've talked about in previous presentations, Alpha-1 antitrypsin deficiency is a genetic condition that is passed through an autosomal codominant pattern, and it's caused due to mutations within the SERPINA1 gene. This gene normally produces AAT protein, which is a protein that's produced in the liver and is transported through the secretory pathway to the lungs, where it regulates the activity of neutrophil elastase. Neutrophil elastase is an enzyme that normally breaks down elastin in the lungs, so we want AAT there to prevent excess breakdown of elastin. It is located on the long arm of chromosome 14, as you can see in the image, and it's located at position 3213. Next. So as I mentioned, it's caused due to mutations in the AAT protein, which you can see on the left image. The first or the most common mutation is the Z allele mutation, and causes the most severe symptoms. Because of the location of it, as you can see the image, it cleaves the beta sheet A in the reactive center loop, which opens it, and the beta sheet A can then polymerize with a reactive center loop of another AAT protein in the liver. And this causes polymerization, which you can see on the right image. And that polymerization causes stress in the hepatocytes of the liver, causing liver disease and liver cirrhosis. And because these AAT proteins can't leave the liver, it reduces the amount in the bloodstream which can travel to the lungs. And in the lungs, neutrophil elastase becomes unchecked and excess elastin is broken down, causing a variety of symptoms such as pulmonary emphysema and COPD. The other allele that's mutated is the S allele, which can also be seen in the image on the left. And this causes a cleavage between the alpha helix and beta sheet, which causes a very unstable form of the protein. And this protein can leave the liver, but is quickly degraded. So again, it has low serum levels in the blood and causes pulmonary emphysema along with other lung symptoms. Next. This disease is fairly prevalent for it being considered a rare disease. It's estimated to be found in 1 in 2,000 to 3,000 individuals, and it is highly underdiagnosed or underrecognized, especially within the US. Within the US, the PiZZ allele is currently diagnosed in 10,000 individuals. However, it's estimated to be associated with 70,000 individuals. So there's a big discrepancy of diagnosis and treatment. Current treatment, because it's commonly misdiagnosed for lung conditions such as COPD or emphysema, is inhalers. However, if you are diagnosed with this condition, there is a therapy called AAT augmentation, where you are supplemented with more AAT to prevent breakdown of lung damage. And other treatments that show promise are drugs that decrease the amount of stress in the liver, or gene therapy, which increases the amount of AAT in the body. Finally, this graph on the right shows a study done in European countries that showed the amount of knowledge of this condition, and it's relatively, as you can see in the image on the regular testing, it's relatively low for physicians to provide regular testing for this condition, and there's relatively low knowledge of it, and these numbers are even lower within the US. So greater knowledge is important for diagnosis and treatment of this disease. Next.
Many research avenues regarding AATD treatments are being investigated by scientists. Augmentation therapy, which is an intravenous infusion of AAT, has been through many trials and is still being researched. This will be discussed later on. Also, different research has begun in epigenetics and genetic modifiers. Epigenetics refers to changes in gene expression that is not caused by DNA sequence change. At a molecular level, there are three distinct but interconnected systems, including DNA methylation, histone modification, and non-coding RNAs, are involved in epigenetic gene expression. Understanding these mechanisms in regard to the initiation, maintenance, and heritability of the epigenetic changes observed in AATD has become a focus in current research. DNA methylation is by far the best studied form of epigenetic change. Studies have shown that there may be a link between changes in the DNA methylation pattern and phenotype in regards to the severity of AATD. MicroRNAs, also known as miRNAs, are short non-coding single-stranded RNA molecules that act as a post-transcriptional level and play key roles in regulating gene expression. So far, the role of miRNAs in AAT has been very little studied, but one study indicated a correlation between miRNAs expression and the severity of AAT related to emphysema, but further research still needs to be performed. Histone modification has been shown to play important roles in liver and lung physiology by modifying a signaling pathway and protein folding, which could be useful in AAD. Several studies have shown that signaling pathway oxidative stress, also known as OS, may be involved in the pathogenesis of AATD. Other studies demonstrated that increased OS leads to telomere attrition in AATD patients and an association between telomere length and AAT phenotype, suggesting that telomere length could be a promising biomarker for AATD disease progression. Some studies link redox states with polymerization and intracellular retention of AAT, suggesting that redox state is a modifier factor for AATD and that targeting OS may be a promising therapeutic option for these patients. Recent research has indicated that serum gamma glutamide transferase, deumosine, fibrinogen, and miRNAs may be possible biomarkers for potential treatments. AAT aggregation therapy is costly and dependent on the availability of the protein, so alternative strategies are being investigated. These new strategies include new delivery strategies, the use of gene therapy, the use of autophagy enhancing drugs, and silencing RNA strategies. Aerosol delivery is being investigated as an alternative, more effective method to deliver AAT to the lungs, and autophagy enhancement as a therapeutic alternative to liver transplantation has attracted a lot of interest lately, which will be discussed next. Next slide.
All right, so current research for this deficiency is examining the effect of autophagy enhancing drugs like carmoxepine or CPZ in the liver. So autophagy is really a protective mechanism during ER stress that can help clear out toxic protein aggregation. So the promotion of autophagy through CPZ could potentially reduce the antitrypsin aggregation in the ER from the Z allele that leads to liver disease. So in this graphic, it is shown that the mutant antitrypsin proteins are unable to be packaged and secreted from the hepatocytes like the wild type. So from the mutant monomers of antitrypsin seen on the left, they can be ubiquitinated and degraded by a proteasome. From the aggregation of this mutant protein due to polymerization, which is seen in the middle, they can be degraded through the formation of the autophagomes and the fusion with the lysosome by the autophagy pathway. So in preclinical studies, they found that CBZ can trigger cell signaling pathways to actually enhance autophagy, as well as the proteasomal degradation. And this is quite important because this could lead to the reduction of mutant protein aggregates that lead to liver disease for patients with this deficiency. Next. So this specific preclinical study led by Dr. Haviji provided the rationale for CPZ treatment for antitrypsin patients. So this study examined the effect of CPZ on hepatic stress from the Z mutant antitrypsin with a mouse model. And they found that this drug increased degradation of the insoluble Z-AAT through the stimulation of autophagy, reducing liver damage. And they also found that CPZ increased proteasomal degradation of soluble mutant Z-AAT monomers that have not yet been polymerized. And these findings are visualized on the right here. Next. So regarding these results, on the top marked by On the top, marked by the letter A, this is a Western plot that has 2 controls on the left and 2 of the treatments on the right for the total insoluble and the soluble AAT. So the thin lines from the treatment compared to the controls show that this drug decreased all levels of Z-AAT in the liver. And the insoluble are the proteins that are aggregated in the ER that degrade by autophagy, and the very, very low amount of the soluble monomers in hepatocytes are the proteins that have not yet polymerized and were degraded by the proteasomes. And with the letters B and C, these are the histochemical and amino stains with the control on the top and the treatment on the bottom. And seen from the purple and the red pigmentation, this indicates that it has the Z-AAT mutant, and there is a decrease in mutant containing globules with the administration of the treatment compared to the control. And with the letter D here, this is another immunostain to show the hepatic green fluorescent autophagosomes with and without this treatment. So on the control on the top, you can really only see just a couple of the autophagosomes in green. However, with the treatment, there is an increase in the number of these green autophagosomes seen within the liver, showing evidence of autophagy enhancement by the drug. And lastly, with letter E, this shows a histochemical stain for fibrosis, which is scarring. And the red stain is marking collagen, which forms within the scar tissue. And comparing the control on the top with the treatment on the bottom, there is a decrease in the amount of red stain or collagen scarring, leading to evidence that CBZ can reduce hepatic fibrosis. Next. So due to these results of the preclinical study on mice, there is currently a phase 2 clinical trial sponsored by WashU over the safety and efficacy of CBZ for liver disease due to this deficiency. And with patients that have ZZ or ZS phenotype with the protein aggregating Z allele, this trial is determining if CBZ will lead to a significant reduction in hepatic accumulation of Z protein of deficient patients with severe liver disease. Next. And this clinical trial is still ongoing, so we still don't know the outcomes of this potential treatment just yet. And in fact, they are still recruiting additional patients to complete the trial because patient recruitment is actually quite difficult for this deficiency due to the rare nature of the disease, as well as its underdiagnosis. And this clinical trial started in 2012, and currently the estimated completion date is this year of January 2021. Next. So the preclinical study, as well as the ongoing clinical trial, is very important for these patients, especially those suffering from the resulting liver damage. And currently, there are no other established treatments to treat liver disease for these patients. And due to the results of the preclinical study, CBZ could potentially increase degradation of the toxic Z mutant protein in hepatocytes as a way to treat the resulting liver disease. And this drug can also lead the way for other studies on other autophagy enhancers and their efficacy in patients, as these enhancers could possibly be used for other genetic diseases associated with toxic protein aggregation, such as Alzheimer's or Parkinson's. Next.
I'll be talking about the current treatment options for AATD. There are no specific liver treatments available right now, as Brittany was saying. They're just still in the clinical trial phase. However, there are some treatments available for lung damage caused by AATD. Now, since AATD causes symptoms that are very similar to chronic obstructive pulmonary disease or COPD, asthma, or emphysema, the treatments look the same, and those include inhalers that are bronchodilators. So you can see that those drugs open up the bronchioles and allow more air to get into the lungs by expanding those airways. Inhaled corticosteroids, so those are also inhalers that can increase the strength of the lungs and their efficiency, as well as just supplemental oxygen therapy. And so sometimes patients just need to be having oxygen throughout the day to help increase their oxygen saturation within their body. As well as we do have augmentation therapy, as previously mentioned, for those individuals that are diagnosed with AATD, which I'll talk about here in a second. Okay, so AAT augmentation has been available since 1988 in the US when the FDA approved a drug called Prolastin C. Now, Prolastin C is a therapeutic that contains human-derived AAT. So that it is, the AAT protein is taken from healthy donors and then purified and suspended in solution. Now, there are some drawbacks with this treatment that can make it sort of difficult, but you will need to be injected weekly for the rest of your life if you are a candidate for this treatment. But once you do, the injected AAT will enter your circulation, and then it will pass through the alveolar epithelium in your lungs into the alveoli, where it can inhibit neutrophil elastase. And I'll talk more about that on the next slide. Some drawbacks from this treatment are side effects. So it's not uncommon for patients to have headaches, fatigue, burning at the site of injection while getting this treatment, as well as the cost. The coverage for insurance for AAT augmentation is kind of hazy. I didn't find any straightforward answers, but the cost up front for these therapeutics averaged about $2,000 per dose. Now, if you think about it, you're getting that once a week for life, and that equals to about $100,000 a year. So adds up quite quickly. Now, as far as the mechanism of augmentation therapy, we have Prolastin C. That was the first drug on the market. Now, Zimera, Aerolast, and Glacia have since entered the market in more recent years, but they all do the same thing. They all have that human-derived AAT in the plasma. The dosing guidelines are the same for all the drugs, and that is about 60 milligrams per kilogram of body weight. Now, you get this infused at an infusion center or at home by a professional, and then that injected AAT will go to the lungs. Before you start this treatment, patients must be tested for IgA deficiency, IgA being one of those antibodies that is found in the blood. Now, if a patient is deficient in that, they can have a severe reaction to this treatment, which would make it not possible for them to be able to be a candidate for it. So that is an important test to get out of the way before you start a patient on this treatment. Now, the lower left picture here just shows a port inside of a patient that can make it easier to inject the drugs. So if you do not have a port, then you will have to have an IV started every single week, which can kind of wreak havoc on your veins. And so it is easy to have a port, so that serves just as permanent access. And now, once that port is set up and the AAT is being infused, it will travel through the bloodstream eventually to these capillaries, as seen in the picture on the right side here. So we have these capillaries that are surrounding the alveoli. Now, the AAT travels through the bloodstream, and it must pass out of the bloodstream through tight junctions in the alveolar epithelium here, now into the lungs. So it is sort of a complex process in order to get the AAT inside of the lungs. But once it does, it's a fairly effective treatment.
Okay, so there is a lot of future interventions for AATD. The big ones are gene therapy, which Sam will talk a little bit more about in a second. And then you also is the inhaled elastase inhibitors, or inhaled AAT, which basically acts as AAT and stops breaking down elastase in the lungs, giving the lungs better function. There's also like the molecular chaperone, which reguides the misfolded proteins and can alleviate symptoms in the liver. Next.
Okay, so currently there's no prevention strategy or cure on the market for AATD, but a promising strategy through adeno-associated virus or AAV based gene therapy in order to maintain appropriate AAT levels in the lungs is in development. AAV vectors have low toxicity and generate stable, long-term transgene expression. The strategy of AAV gene therapy is to augment lung levels of AAT by delivering the normal human M-AAT cDNA using a gene transfer vector. This allows the transduced cells to secrete the protein in the blood after a single administration. The best target tissue for AAV treatment is still under investigation, since the efficiency depends on the type of receptors located on the cells. There are 3 possible tissues for AAV vector infusion, and these are the muscles, the liver, and the lungs. Since the lung is only 2% of the body weight, delivery of an AAV vector to the muscle or liver is inefficient, and most of the alpha-1 antitrypsin does not reach the lung. So for gene therapy, this requires high doses, and that can lead to liver inflammation and also decreased muscle health. Therefore, the most successful strategy for treating AATD in the lungs is to deliver the vector directly to the lung. This can be done in 2 ways. First, the respiratory epithelium, or through the lung pleura. Due to the immune defenses located inside the respiratory epithelium, the most successful and direct AAT delivery should be through the lung pleura. Intrapleural administration of the vector should provide production of AAT locally around the lung parenchyma, and thus provide high levels of AAT within the lung and systemically. Gene therapy is in the later stages of clinical trials, and if effective, it provides lower risk and fewer issues with supply limitations and reduced overall drug costs compared to augmentation therapy. And this graph here on the right shows administration of AAV2 and AAV5, both intramuscular and intrapleural in mice. This shows that the AAV5 vector is more efficient, and that overall intrapleural administration is much more efficient than intramuscular. Next.
Okay, so the most promising treatment route is gene therapy with CBZ. Gene therapy can provide relief to symptoms in the lungs at a lower cost augmentation therapy and less risk for the patients for like reactions to the drug or having to get weekly or monthly treatments. It is a one-time treatment. CBC is a medication, so it's easily accessible and can provide relief in the liver. These combined could provide relief of all symptoms from AATD and could be a long-term treatment for the patient. Next.
So in summary, alpha-1 antitrypsin deficiency is an underdiagnosed genetic disorder that increases the risk of lung and liver disease. Presently, treatment for individuals with AATD is augmentation therapy or the direct infusion of AAT in the blood. And this is also combined with treatment of COPD and emphysema. Current research regarding the treatment of AATD includes chemical chaperones and CBZ to lower hepatic accumulation of AAT through autophagic clearance of Z-AAT. This results in a reduction of mutant protein aggregates and in toxicity, and therefore liver damage. The use of synthetic elastase inhibitors and inhaled AAT treatments are being investigated in their ability to reduce the effects of AATD in the lungs. Through the transduction of cells to secrete M-AAT, gene therapy is another promising strategy to prevent and cure pulmonary manifestations of AATD. Alpha-1 antitrypsin deficiency remains an important challenge for clinicians, as increased recognition is needed in order for emerging treatments to be effective in the future. Okay,